So continuing on with our look at anatomy and other considerations, especially with respect to osteopathic manual therapy, keeping motion as our central point of meaning or the central point of our semantic network or our network of meaning, we're looking at head motion. Now, we've already touched on this for the most part with respect to cervical flexion, cervical extension, cervical side bending, and rotation, where we've noted the difference between cervical motion as well as motion of the head on its own or on a relatively still neck. But what we want to do is maybe use head motion to look at the stuff that's inside the head. So what we're going to do, our main objectives, a specific discussion of what head motion is. So we've already done this more or less with each of the cervical motion pieces, but what we want to look at is breaking it out and just being clear again. So often I will note that the point is to be redundant as possible, as often as possible, so that you start to have specific pieces of information as well as a central meaning point. So motion is a central meaning point, or the central meaning in the network, but we have different motions. And what we want is different networks. So each network could be considered a motion. So you got a big network, which is motion. Each motion is its own network. But then what we want to do is have a lot of redundancy in those different meaning subgroups in the network. So each motion, so cervical flexion, cervical extension, we want crossover. We want as much of that as we can get so that the same points keep getting touched. And you see how the individual details, the individual factoids start to blend into all of these different networks. So we do want a bunch of that redundancy. So we'll talk about planes and axes with respect to head motion. So just very, very simply, you have a relatively still neck and a moving head on that relatively still neck. So that just takes care of the relational motion portion. But we'll talk about the planes and axes. We have a general discussion of the bones of the head. So I'm going to make a special note. I'm going to simply argue that there's not much of a point in attempting to move these bones. There are people within the osteopathic profession that are very, very interested in the concept of moving these bones, especially because there are sutures or the joints between the cranial bones. At one point, very, very early on in life, there is some mobility to those, but it fuses, right? So the main point of the mobility is for the birthing process, but after that function is not maintained. Moving of the bones in relation to the individual or in relation to the head or the brain is not particularly smart because that would put undue stress and strain on the brain and the connective tissues within. So it fuses. So the attempt to move them, probably not the smartest and probably not likely happening. It doesn't mean that cranial treatment doesn't do something to the patient. It just doesn't move the bones of the skull. And if you're talking about a child, you shouldn't often be moving the bones of the skull. There may be some times where some sustained pressure to change the shape of the skull so that it fuses and unionizes in a more appropriate shape, but that is not necessarily done with short bursts of osteopathic treatment or other hands-on treatment. That's often well done by helmets, like molding helmets. Now, it doesn't mean that osteopathic treatment has no benefit when performed to the cranium. It just means the benefit is not likely moving of those bones. We'll then move into a general discussion of the muscles that move the head. We've already done this in each of the cervical motions, so cervical flexion, cervical extension, and then cervical side bending and rotation, but we'll go over it again for that redundancy. General discussion of the cranial nerves, so we'll be broad here. We'll subgroup them by their functions, so the groups of nerves that have shared function. General discussion of the vascular supply, so the arterial supply, the venous drainage, as well as the CSF flow. A lot of people in osteopathy get very, very interested in the CSF flow, but I will again make the argument that, first of all, it's not a settled topic how it actually works and the directions it actually moves. It's sort of, there's some agreement, but the mechanism of motion of CSF is not completely agreed upon, and there may be multiple mechanisms. So we'll have a very, very brief touchstone there. And then we'll have a general discussion of the areas to assess and treat should head movement issues be suspected or reported. Again, as I've noted time and time again, once you get above the clavicles, all the areas that you're going to be considering are the same, but maybe we'll talk about a different angle on why you would do those things, or a mildly different angle. So we talk about flexion, extension, side bending, and rotation with respect to the head. So the sagittal plane is a 50% cut left to right. The horizontal plane or transverse plane is a 50% cut top to bottom. The frontal plane or coronal plane is a 50% cut back to front. Now the head on the still neck can move in all of these planes. The axes are perpendicular to the plane. So the sagittal plane has a transverse axis or a horizontal axis. The horizontal plane has a vertical axis, or the transverse plane has a vertical axis. The frontal plane or the coronal plane has an AP axis or a PA axis, right? So you can have movement in the sagittal plane, movement in the transverse plane or the horizontal plane, and movement in the coronal plane, right? So relatively still head moving, or sorry, relatively still neck, moving head. It doesn't mean that some motion of the neck won't happen when you get some smaller cranial motions or movement of the head on the first cervical, but just to go over planes and axes again, so it's consistently redundant, we have that brief discussion. As far as the bones of the skull, so there's many bones. You're going to have people break this up in different ways and use different terms for categorization. So there's the neurocranium and the visceral cranium. There's the skull proper, and then the facial bones. There's different ways to break this up, but in simple essence, right? So the big ones, you've got the frontal bone, which when you're born is two separate bones, right? And then they fuse, but you've got the frontal bone, the parietal bones, right? The temporal bones, and then the occipital bone on the back. Now, obviously the picture isn't going to show the occipital, but you're going to get some concept there. Now, then when we go forwards into the smaller bones, you've got the sphenoid, which again is a bone that osteopathic practitioners get quite interested in because of its attachment or its union with the occiput or the occipital bone. And this is based on a mistake. That movement or that joint, which is patent in younger people, I believe is often fused by the mid-teen years. So there might be some motion in very, very young children and very, very minor motion in teenagers, but it's gone by the time you're in the middle of your teen years. And even still, to purposely move that, if you can, might cause undue stress and strain throughout the tissues that are contained therein, which would be vascular tissues, the brain itself, and then subcomponents of the brain. So it's not the smartest thing to try to move, for the point that the purpose, very broadly speaking, of the cranium is to protect the brain, right? So you've got thick bones and very little motion to protect the brain. But you've got the sphenoid bone, you've got the nasal bones, the lacrimal bones, the zygomatic. So on the temporal bone, you've got the zygomatic portion of the temporal bone and the temporal portion of the zygomatic bone, which make the zygomatic arch. Then you've got the maxilla and the mandible, and then midline. So you've got the ethmoid and the vomer. I believe I didn't miss any, but the basic idea is you've got a bunch of bones that come together to make all these structures. They're somewhat mobile prior to and at birth, and then they lose their mobility because of union of all of these structures throughout the lifespan, some earlier than others. But basically, by the time you're in your mid-teen years, there should be nothing within the skull that moves aside from the mandible, at least in a notable way. Then you'll see on the diagram the supraorbital foramen, the infraorbital foramen, the mental foramen, and then you'll see the superior orbital fissure. You can't see it, it's not noted there. And then the inferior orbital fissure through the sphenoid. So you've got essentially passage for all of the cranial nerves, which we'll touch on. Right, the head movement on the front side. So if bilateral contraction occurs, to obtain head flexion, talking about longus capitis, rectus capitis, anterior and lateralis, and really not much else as far as specific head flexion is concerned. On the back for head extension, splenius capitis, semispinalis capitis, longissimus capitis, rectus capitis, posterior major and minor, obliquus capitis, inferior and superior. And then any of those that we've already mentioned, when they contract on one side or the other, you will get some combination of side bending or rotation depending on the nature of the movement that is being created. But we've already touched on these muscles, especially in the cervical portions, but we want to touch on them again, just that redundancy. So longus capitis on the front, rectus capitis anterior and lateralis on the front for bilateral flexion or side bending and rotation, one side or the other. Longissimus capitis, splenius capitis, semispinalis capitis, then rectus capitis, posterior major and minor, obliquus capitis, inferior and superior. And then there are all other small muscles that may contribute a little bit, but not particularly likely, because most of the intervertebral muscles are replaced with the suboccipitals once you get to see the head on C1. As far as the cranial nerves are concerned, so we've got a general picture here. So if you're looking, usually the best place to see the cranial nerves is from an inferior view of the brain, and you'll see the spinal cord as it traverses upwards or really traverses downwards from the base, from the brainstem, from the base. But what you'll see is how these all, in an organized fashion, split off of the brainstem and the accompanying nuclei. There are commonly 12 termed cranial nerves. There is now some agreement, or the beginnings of some agreement, that cranial nerve 0 is present. It does seem to have more agreed upon function in non-human mammals, right? So it's there. Part of the reason that it wasn't noted before was because of dissection technique. So it was basically obliterated by the time you looked. So there is some dissection technique that does suggest that cranial nerve 0 exists. So you could say 12 cranial nerves because that's the constant standard, or you could say 13, but it's cranial nerve 0, so it's kind of non-existent, or at least you could call it that. It doesn't seem to have any function that we can identify yet. So if we group the cranial nerves by function, smell is cranial nerve 1, or the olfactory nerve, and that's coming through the ethmoid, so it goes forward and comes through the ethmoid. Vision is the optic nerve, or cranial nerve 2, so that's the one that allows you to interpret light signals. Eye movement, we've talked about this with the extraocular motions, so the oculomotor nerve, or cranial nerve 3, the trochlear nerve, and the abducens, which is cranial nerve 6. Facial sensation and chewing is the trigeminal nerve, so cranial nerve 5, or V, right? So you'll get the following branches. You'll get the ophthalmic nerve is V1, now that's sensory to the forehead and the nose. You get the maxillary nerve V2, which is sensory under the eye, so you kind of get this strip here, right? And then V3, the mandibular nerve, is sensory more or less along the jaw, some of the cheek, but more or less along the jaw, but also motor to the muscles of mastication. Then you get facial expression, which is cranial nerve 7. You get many branches. We've talked about this with respect to the mimetic muscles when we were talking about facial expression and or muscles of facial movement. So the posterior auricular going backwards, the temporal, the zygomatic, the buccal, the mandibular, or marginal mandibular, because there is the mandibular nerve, which is V3, so it can be somewhat confusing, and then the cervical nerve, and that's mostly the platysma, but you've basically got this. Right, so, and that goes to the parotid gland. Hearing and balance is the vestibulocochlear nerve, or cranial nerve 8. Oral sensation, taste, and salivation is the glossopharyngeal nerve. The vagus nerve has many, many functions, so you can't really group the vagus nerve by functions, but basically it is broadly parasympathetic and sensory to most organs, or really all organs outside of the head, up to the hindgut. So the hindgut is the last third of the transverse colon, the descending colon, and the sigmoid. So basically sensory and parasympathetic tone to all of those organs: heart, lung, liver, large intestine, small intestine, or most of the large intestine, pancreas, all of those things comes off of the vagus nerve. It is called the wandering nerve, or the vagrant. Head movement and scapular elevation, we've talked about this with respect to cervical motion and head motion, but it's the spinal accessory nerve. So the spinal accessory nerve, because I forgot to note the SCM as a head extender. So the SCM and the SCM and the trapezius receive tone from cranial nerve 11, or the spinal accessory nerve. So if you see this and this, that's what cranial nerve 11 does. Tongue movement is the hypoglossal nerve, or cranial nerve 12. Now, there are quite a few ganglia for parasympathetic and sympathetic function inside the head, in the head and the face. We're not really going to go through those, but they do exist. So things like salivation, things like snot and tears, you're going to have specific ganglia that are related to all of these nerves, or some of these nerves anyways, that provide those functions. As far as arterial flow, really what you're talking about is the vertebral arteries as they ascend through the neck, as branches either directly off of, if I remember correctly, off of the left brachiocephalic trunk and then off of the right subclavian, but they go up through the transverse foramen, sometimes giving off branches to some of the deep cervical muscles, the anterior muscles, depending on what source you read. And there's disagreement on that. So you can leave it blank, or you can say that maybe that's the case. It would depend on the specimen or the person. Then you're going to get that going up and coming together essentially in the I forget the proper name of the passage or the cranial inlet outlet. I forget the proper name of it, but basically they merge and they go in and they run up the cord. They will provide the blood flow, the arterial blood flow down the cord. So 2 anterior and 1 posterior in most descriptions, 2 spinal arteries. Then you're going to have a bunch of branches off of that. And then the internal carotid, as it branches off of the common carotid and then goes into the carotid canal, will provide blood. So the vertebral arteries are mostly blood to the back of the brain, so the brainstem, the cerebellum, and the back of the brain. And then the internal carotids are going to provide blood to the front of the brain in most cases. As you can see in the picture, they draw the circle of Willis on the bottom of the brain, and then you get all these branches coming off. Now, the circle of Willis is very, very rarely comparatively complete. It is a great description of how this all works, but there are times when it's not a full circle. All these arteries don't always anastomose. But the description, so that you can understand it, is best done with the caricature of the circle of Willis. I believe there is, depending on where you're going to read, it's often only 25% of people present with a complete circle of Willis. Sometimes it may be a little higher, sometimes a little lower, depending on the source. But the circle of Willis is a great description, so you can understand how this works and which arteries will communicate with one another or provide blood flow to particular areas of the brain. But that said, it's not often complete in most people. The dural venous sinuses, this is something that, again, osteopathic practitioners often get very, very interested in, because they are of the belief that if they move particular bones, because of the way that these venous sinuses are created by the meningeal layers, that you can influence the venous drainage of the brain or the cranium, generally speaking. Now, again, I will make the argument that these bones really shouldn't move, because if these bones moved and you started to have shear through them, you would be pulling directly on the meningeal system and directly on these venous sinuses, and you'd be changing the pressure gradients, and that would not be particularly good. So pulling on the brain and the nerves therein, pulling on the sensory nerves that will be on the scalp, and then putting differential pressure through these things, probably not a good idea. The place that you're most likely to have an impact on both arterial flow and drainage is essentially the neck or the head on the neck. So basically clavicles up. But you have the superior sagittal sinus, and people like to talk about the, I forget the name of the suture, but the superior sagittal suture, I believe. Yeah, the sagittal suture, rather. So you've got the superior sagittal sinus, you've got the inferior sagittal sinus underneath it. So those are basically in the medial sulcus of the brain. There's a proper term for that escapes me at the moment, but you basically have those there. The great cerebral vein is essentially pulling from areas around the pituitary and the hypothalamus. And you get the straight sinus, which goes back, then the confluence of sinuses at the, basically where the parietals, temporals, and some portion of the temporal and the occiput, right? So the temporal is going to end a little further forwards, but you've got this confluence. So there's confluence of sinuses. You have the superior and inferior petrosal. So those are basically kind of behind the jaw and underneath the brain, or in and around the cerebellum-ish, brainstem-ish. Then you have the transverse going forwards and the sigmoid going down, and the inferior petrosal and the sigmoid join, and that becomes the internal jugular vein. The internal jugular vein is essentially most associated with the SCM. So the SCM, once again, becomes important. So if you're considering some sort of buildup of pressure in the head, then the best thing to do is move the head in relation to the neck, as opposed to trying to move the cranial bones, because again, those cranial bones are not necessarily built to move, at least past very, very early infancy, and less so as you get to your mid-teen years. By the time you're in the mid-teen years, there should be nothing left. There should be no patency left in the sutures. Then you look at CSF flow, again, something that people get very, very interested in. So you have the various foramen, right? So, or the ventricular system. So you basically have some form of flow through the meningeal system, I believe between the arachnoid and the pia, if memory serves me correctly. You're going to have, generally speaking, accepted flow up to the superior sagittal sinus. So the superior sagittal sinus can be considered the main reabsorption point, but there is information available to suggest that it may not be. The reabsorption point may be, or points may be, more diffuse. Then you have your ventricular system, you have your lateral ventricles, the choroid plexus is where the cerebrospinous fluid is more or less generated. There's some relationship to the arachnoid villi, but you're going to have your lateral ventricles, the third, so that's kind of 1 and 2, or like, because there's 2 of them. Then you have the third ventricle, you'll have the foramen of Monroe, the aqueduct of Sylvius, you'll have the fourth ventricles, right? That's down more in the cerebellum, but you have this general flow. So it's kind of made in the middle of the brain, more or less. It's going to flow downwards, and then it's going to flow through the cord. And then depending on where you go, yeah, so these, it's coming out of the fourth ventricle. So there's some down to the middle of the cord or somewhat, and then there's down the meningeal system of the cord, and there's some that's going to go up. How this moves around, there are varying interpretations of this. This is not necessarily something that is, I understand, as a determined mechanism. I've seen some that says it relies on essentially thoracic respiration. So the changes in pressure gradient through the torso generally, or the thorax generally, is going to put a lot of tension throughout the full body. It's going to change pressure gradients. It's going to pull on structures. And as it does that, it will also change some tension through the vertebral bodies and the vertebral column, and then pull on the connective tissue to some degree within the spinal cord. So there's some pump believed to be happening through that pressure change. There's also the arterial pulses. So the arterial pulses off the circle of Willis and all the associated arteries are going to essentially, because it's a closed box, there's some possibility that it creates kind of a reverberating wave that helps the pulse of the cerebrospinous fluid and the movement of therein. Your average in most cases is about 150 milliliters of fluid within the ventricular system, as well as in all of the meningeal spaces, which is not a lot. Hydrocephalus, I believe, is considered to be approximately 300 milliliters. So between 150 and 300 milliliters, you're considered to be getting into trouble. So moving on from the flow of cerebrospinous fluid, where, as I noted, that once you get to about 300 milliliters of cerebrospinous fluid within the system, it's considered hydrocephalus, or swelling of the head or swelling of the brain, and that's putting quite a bit of pressure on all of the structures, making it harder for them to function as would be expected. So moving on from there, we very generally consider the hormones, hormonal axes and places that those occur in with respect to the brain, especially looking at the hypothalamus. In this particular diagram, it says the pineal gland for melatonin. I've heard the pineal gland, or sorry, melatonin coming from the reticular formation, so there may be something that my memory isn't perfect on, or maybe something that I haven't seen as a development, but generally speaking, some combination of the pineal gland and the reticular formation are for melatonin. But the hypothalamus is mostly releasing hormones or prohormones, or the hormones that tell other hormones to show up and do what they're supposed to do. And that's going to be based on varying feedback mechanisms. So a kind of feedback or a feed forward, or a positive feedback loop or a negative feedback loop. So a few of these will be different. Essentially what you're looking at is, this is just in and around the sphenoid, because the pituitary gland sits in the sphenoid. I believe the term is cella-turcica, or the space where it kind of drops out from the brain and into that portion of the sphenoid where there's a ton of blood. So I believe that's in the cavernous sinus. So there is an artery going through the cavernous sinus to provide arterial blood, but there's also veins, right? So you've got a bunch of stuff going through there that allows for venous blood to be carrying hormones to get to the to some degree to be around, and then also the arterial blood being close, so you can have the blood-brain barrier more or less in there, where hormones can get in and then signal, and then it can drop out. But mostly the hypothalamus is essentially hormone releasing or releasing hormones is a better way to say it. And then the pituitary, you have the anterior pituitary and the posterior pituitary. The anterior pituitary is usually hormones themselves that will then be taken, I believe the proper route is into the venous blood from there, so into the cavernous sinus, then through the dural venous sinuses to the internal jugular vein, to then be dispersed throughout the body. So it would get to the heart, and then it would pump out. So kind of in cardiac circulation or pulmonary circulation, get to the heart, then to the lung, back to the heart, and then out. But the anterior pituitary, you've got growth hormone, thyroid stimulating hormone. So again, there's like thyroid releasing hormone, or whatever, I can't remember that one particularly, but adrenocorticotropic hormone, follicle stimulating hormone, or FSH, luteinizing hormone, or LH, prolactin, more active in females, probably some action in males, but very little. The posterior pituitary is essentially oxytocin and vasopressin. So the I don't know why there's oxytocin there twice. So there's the stored oxytocin and the antidiuretic hormone. So vasopressin essentially is fluid balance throughout the body, for fluid balance, because it's going to act on the kidneys, which will then act on essentially certain things in the blood to maintain fluid balance. Then you're going to have the thyroid. So we've already touched on the thyroid when we're talking about hyoid motion. But again, the hypothalamus very generally releasing hormones, the pituitary very generally hormones themselves, and separated between the anterior and posterior. The ability through hands-on work to really heavily and accurately influence these things is very low. It doesn't mean you can't have a positive impact on a patient with hormonal issues, but it's not necessarily because you're doing the movements that you're generating in the patient are going to accurately and specifically affect a hormone. It'll be just very general health state and very general ability to change pressure gradients, to move blood around, and to move the cerebrospinous fluid around more effectively or with less restriction. But again, it's not hands-on therapy would be very, very non-specific to these things. If it's going to have a positive impact, it's going to be because you're changing pressure gradients, and you'd have to be able to prove that the pressure gradient was a problem, which is very difficult to do. So focusing on these things and aiming at these things is low yield for osteopathic manual practitioners. You can have a positive impact on patients who have these issues or issues with these structures. It doesn't mean you're targeting those structures. It means you're having a positive impact on the patient. And if you're having a positive impact, it's probably because you're doing something good to pressure gradients throughout the body. All right, so you're non-specific to these things, but understanding them can help you understand a patient, as well as when you might want to have them referred on to a higher level of care, or a level of care that can do things you can't. So your areas of consideration for assessment and treatment, as I've noted many times, once you get to the clavicles and go up, these are more or less all the same. So with respect to the head, the movement of the head, you want to consider the scapula and the clavicle. So the scapula for the trapezius, the clavicle for the SCM more than anything else. And there is a part of the trapezius that's on the clavicle, kind of wraps around forwards. You're also considering the levator scap to some degree because of what it's going to do to the neck, right? The omohyoid in particular, because the omohyoid is going to go to the scapula, and it's got that tendinous connection to the carotid sheath, and it has the ability to place tension or change tension on the carotid sheath, which is containing the internal jugular vein. So that helps with blood or the pressure on the jugular system, more or less. So that will actually have some ability to have at least minor or non-specific impact on draining the head and neck. The hyoid, mostly again, the omohyoid here, but the others obviously matter because the position of the hyoid and some abnormal tension that the other hyoid muscles, be them infra or supra, will have on the omohyoid and the carotid sheath may have some value. Again, it's non-specific because it's just generally pressure gradients. But so you're not going to aim at a particular hormone. You're going to aim at pressure gradients through mechanical tension if there is a notable problem. And then if you have proof otherwise that it has this cascade, because you're only predicting that it has this cascade. And even if it doesn't have that cascade, better movement of the hyoid can have other positive effects on the patient. The SCM specifically, no, this is again with respect to the internal carotid or the connection of the SCM to the carotid sheath, right? So we're all again talking about the pressure gradients that will allow for movements of fluids. The cervical vertebrae, very generally speaking, so partially this is because of the vertebral artery, but partly it's also just because of the the tension that can be transmitted through the relationship of the bones to the muscles, and then that pressure system or the impact that it would have on especially the jugular system may again have a non-specific effect. The upper ribs, so you're considering the subclavian circulation and the scalenes essentially being passage points or points that can essentially impact pressure gradients with respect to the subclavian artery, as well as the subclavian vein to some degree. So if there's higher pressure on the subclavian vein, it's going to have a harder time accepting blood from the jugular system because it needs to be maintained at a low pressure. Otherwise, you're going to have maybe slower or more inappropriate venous drainage there. The upper ribs, again, as I just already noted, so I just went through that, kind of go farther on now. Any changes, so if you have reason to think that any functions of cranial nerves or any functions of hormones may be having some issues, you really want to refer out for another type of investigation, because investigating movement is not necessarily going to tell you what's going on with these particular hormones, with these particular cranial nerves. You can get a really good superficial signal that says somebody else needs to look. Now, any changes in cognitive function, so memory or speech are the easiest ways to see this. Any change in salivation, this would be pretty dramatic and pretty notable, because for a patient to report it to a hands-on practitioner, they're more likely to report it to their physician. Any changes in vision, especially rapid ones, any changes in tongue movement or tongue sensation or swallowing should bring attention. Now, if any of these changes are rapid, it's an immediate referral, right? You want to be very careful because these structures are sensitive. They have wide-ranging impacts, especially within the head. But all of this is going to come off of identification of the reports, right? So the symptoms, so the symptoms being the things that the patient can identify and nobody else can, or signs, so changes in ocular movement, changes in movement of the jaw, right? Changes in speech or memory. You can't tell changes in the vision. The patient has to report that. So that's a sign more than a symptom, or rather that's a symptom more than a sign, because the patient can report it and you can't tell, at least by testing the way that an osteopathic manual practitioner would. But if any of those changes are rapid, again, immediate referral. But movement of the head on the first cervical has the ability to locally impact the pressure network or the pressure environment to allow for movement of fluid in and out. And then the SCM, specifically the clavicles, generally the first two ribs and the scalenes, this can all have a very non-specific impact on all of these functions. But again, you can't target a hormone. You can't target a cranial nerve necessarily, maybe aside from the vagus. To some degree, you can have some impact on it. So there's vagal massage. So some people will do it up here. You can get into the vagus and the region of the recurrent laryngeal, essentially medial to the SCM at the clavicle. And you can have some temporary impact on the vagal tone, as can be read through heart rate. Usually the heart rate will go down and then it'll escape up and then go down again and then escape up. So you get what's called vagal escape. So you can see those types of phenomenon, but it's not likely that you're going to have a chronic impact on the vagus by treating the clavicle or treating the SCM. You may have a short-term impact on it, but then the body is going to go through homeostatic processes and regulate itself. So again, very generally speaking, with respect to head movement, if you see any changes in functions with respect to cranial nerves, especially eye movements, movements of the jaw, movements of the face, or the ability to move the face, changes in salivation, you're not going to see those. The patient will report those to you. Changes in vision, the patient will report those to you. Changes in hearing or balance, these are all things to be curious about. Locally, you can move the head on the first cervical. Generally speaking, you can move the SCM, the neck, on broadly, the clavicles, the first two ribs. And these are all things that can have a very non-specific effect on the pressure environment to allow for movement of these things, as well, or movement of fluid, as well as movement of varying substrate through nerves, because you do have axoplasmic flow, so movement of things through the nerves. So you can, again, have a very non-specific effect on the stuff inside the head, and I wouldn't argue for even attempting to move the bones of the head in almost any case. I would say that that's fairly dangerous if it's possible. You want to exercise extreme caution.